Good afternoon, everyone. Thank you to be with us for this last session today. I will just remind you to turn off your cell phone to make sure we don't disrupt the presentation. So I am Nathalie Ouimet, the Vice President at Montréal in Vivo, which is the life science cluster of the Greater Montreal. The cluster is working on fostering the economic development around personalized healthcare since 2009. So I'm really happy this afternoon that our sister organization, the Quebec Network for Personalized Medicine, is leading the presentation of this international congress. I think we had very nice talk since this morning. So I'm pleased to introduce you to Mr. Peter Goodhand, which is a leader in global health sector as a senior executive and board member in the Health Research Advancement Community. Mr. Goodhand played a key role in the creation of the Global Alliance for Genomic Health to accelerate progress in genomic research and medicine, and in June 2013, he was appointed Executive Director of the Alliance. Prior to this role, he was the President and CEO of the Canadian Cancer Society, Canada's largest health charity. Before joining the charitable sector, Mr. Goodhand had 20 years' experience in the global medical technology industry, and he was the founding managing director of the Health Technology Exchange in Ontario. The title of his talk is Global Genomic Knowledge, Local Precision Medicine. Please welcome Mr. Peter Goodhand.
Thank you, Natalie. I'd also like to thank the organizers for inviting me here to tell you the Global Alliance story, for those of you who have not heard it before, and also some of the lessons learned in this context of how we move from global research to local precision medicine. I'd also like to thank Bartha and David Altshuler yesterday for telling you all about what's coming, and Victor this morning for also setting me up. Hopefully I can deliver on their promise. But equally I'd like to thank all of you for hanging in to the end of a long day. As Natalie just shared with you, I am not a researcher or a healthcare provider, but I have spent most of the last 20 years in either the public, the private, or the philanthropic sectors trying to move health research into better products, better practices, better policy, so that interface. The last 3 years of that have been at the Global Alliance for Genomics and Health, and for the last month as the interim president of the Ontario Institute for Cancer Research. So I'm not quite sure which is my day job at the moment. Just quickly through these first few slides, but we often talk about big data, and when we talk about it in this context, it clearly has been driven by this massive drop in sequencing costs, and we are heading to that $1,000 genome. I thought we might have actually got there in some of the conference material, but then I realized it was $1,300 US, not Canadian, so we're still not there yet. What that's resulted in, if we look at the number of genomes, that first decade took about $3 billion to provide 2 genomes. The next decade, and I'm fudging the numbers here, about $4 billion, I guess, for somewhat over 100,000 genomes if we track all the pieces around the world, and we're probably still in that phase. They're growing rapidly. If we look forward to that 1,000 genome, there'll be 1 million genomes in front of us for $1 billion. So, unparalleled generation of human genetic data, how do we unlock its potential? A way that allows it to be shared on a global level, and thus empowering personalized or precision medicine. Bartha shared this with you yesterday. We need data from millions of samples, but that takes new organizational methods. Typically, that data was by silos of disease, country, institution. The analysis methods were non-standardized and very few at scale. Certainly not a scale which would deal with the previous slide. And our approaches to regulation, consent, and data sharing actually limited interoperability. The people who founded the Global Alliance saw this and realized that if they didn't act, an overwhelming mass of fragmented data, such as we see in electronic medical records, a tsunami of new data. What we needed was collective action to achieve that interoperability. The kind of interoperability we see with global telecommunications. For those of you with an iPhone on Bell in Canada, if you could only talk to other people on an iPhone on Bell in Canada, limited utility. So imagine how us BlackBerry users would feel with nobody to talk to except other BlackBerry users. The point is those devices can talk to each other, the networks talk to each other anywhere you travel. And that requires technology interoperability, but it also requires trusted business relationships between you and your provider and that provider wherever you travel. And without those two things, you would not, your phone wouldn't be particularly smart. So the folks said that rather than talking about it conference after conference, we should act and form a global alliance. Well, to show the mission, I usually emphasize on this slide that the mission was never about bigger research, better research, faster research. It was about creating an environment in which research could actually improve human health in a timely manner, and that we do that through common frameworks and through catalyzing actual data sharing projects. What we do, it's funny, Martha mentioned the first, everything except the last one. I usually go right to the bottom line and say all those other things are necessary, but the bottom line is this global alliance is for those who commit to responsible sharing of data. If that's not something that is of interest to you, then this alliance is not for you. What we don't do, is, as Martha again said for those of you who are here, are those things, but on that last point, again, I'll pause and say, many of our members actually don't have data that they could share. They're in the business of enabling data sharing rather than being data owners or data users. So the alliance is very much about the ecosystem of people who have the capacity to enable others to share data, not just people with data themselves. Very much international, as much as we can make it. And we moved, in the beginning, I think we were very stuck on standards, rigid standards, formats. And more we've moved to interoperability, and I'll come back to that later. We do support pilot projects and demonstration projects because we didn't want the tools we develop to sit on a shelf or on a disk. The other thing that we knew from the beginning, but I think we've heard at this conference and elsewhere, in order for us to move this field forward, we need to engage both the professional communities and the public, and we need their trust. And that trust is hard to earn, and it's very easy to lose, and we must remember that. This is our organizational model. We have a steering committee. It started with 8, it went to 12, it's now 14. So of course we had to form an executive committee of 5 or 6 within that. We have a strategic advisory board. They're all volunteers. The secretariat, which I help steer, guide, manage, is located in different locations around the world, but they're the dedicated employees of the Global Alliance. And then we've got these working groups, the 4 of them. There could be a 5th. I hope they will be soon. And those working groups generate task teams that do very specific deliverable tasks. We have a different relationship with our demonstration projects. They're not of the Global Alliance, they're with the Global Alliance. So our leadership chair at the moment is Thomas Hudson, who is just leaving OICR and headed to AbbVie in the US, and will be stepping down from our steering committee, and so the search is underway. Members of our steering committee and also co-chairs of our working group. This is our strategic advisory board chaired by Harold Varmus and includes people like Francis Collins, Susan Desmond-Hellman from the Gates, Eric Lander, Mike Stratton, Sharon Terry from the patient group. So a very senior strategic advisory board. Harold asked us to call it strategic because he didn't like the idea of being called senior. So we went with strategic. In terms of membership, we have 400 plus, I think it's 411 at the moment, organizational members, 700 plus individuals, and between them, they're active in 70 countries. Martha made the point that this is very much not an alliance of one sector. It crosses all sectors, and the largest single component is life science and information technology companies. And I'm looking at this slide now thinking I need to go and rejig those percentages because I think it keeps holding to that rough percentage, but we'll recalculate. The message here, though, is it's not one sector, it's not one country. It is truly, at this point, a global alliance. Those are the 70-plus countries represented. If you're from one of, I understand there are 13 countries at this meeting. So if you're from one of those 13 countries, if you are from a country that's not on this list, see me as I run out of the door at 6 o'clock, because I would love to get you in this organization. The host institutions for the Global Alliance, the Ontario Institute for Cancer Research, where I'm based, the Wellcome Trust Sanger Institute on the Hingston campus, in Cambridge, near Cambridge, UK, and the Broad Institute of MIT and Harvard in Cambridge, Massachusetts. Those three institutions bore almost all the startup costs of the Alliance and still are significant funders of it. So it was those big genome research centers seeing the potential for this and being prepared to put their people, their dollars into starting this alliance. More recently, we've been joined by NIH, Wellcome Trust, and in Canada, Genome Canada and CIHR through a program called CanShare, which has made a significant difference on the ability of Canadian researchers to be able to support the work of the Alliance. Those are the four groups. I won't dwell on them, but there's clearly, this came out of the big genome research centers. And yet, since there was that commitment to make sure it was clinically relevant, we said from the beginning we need a group that can focus on the clinical dimension and make sure that what we're doing is relevant. I think those two worlds are now coming together, and other groups that have historically been more at the clinical setting are now working with us, and we're trying very hard to make sure that we don't duplicate our efforts. There's a number of volunteers involved in those, and as with every other organization, we may have double counted, because I'm sure there's one volunteer that's in at least 3 groups and 2 projects. So it's a measure of volunteer activity rather than unique individuals. You can see that the data working group and the regulatory and ethics groups are high engagement. It feels like that when you look at the 10 projects they're doing at any given time, and they could have 10 to 30 people on each team. Projects are quite different, but that's the energy. This page is where those individuals are making a real difference. How we work is those 4 working groups are where our needs and assessments are prioritized. They create the task teams that do the work. Those task teams do tools and solutions. We make them publicly available. So these tools and solutions that come out of our work would then be completely available to anybody in the world, but we also embed them into our demonstration projects. And the purpose of doing that is so that we can have that cycle of learning. We almost never get these tools right the first time. The important thing is that we learn from their first pilot, move them back in, improve them. And out of that should come member input or external input on what new needs are identified. So that's the cycle by which we do our work. To date, we've got 55 deliverables or tool solutions at some point on this pipeline. We've got 27 that are currently in that design discussion stage, 16 that are in active development, and we've moved 21 products out of the pipeline. Doesn't mean they're finished. In fact, they'll probably cycle back in again and get improved. I just highlighted on this 3 major documents that become fundamental. On the data working group, it's about the application programming interface, the API. On regulatory and ethics, it's the framework that Martha shared with you yesterday. And from our security working group, it's the security infrastructure document. So those 3 are pretty much fundamental pillars of most of the rest of the work that you see on here, although there is some distinct elements. Framework is available in 12 languages. One of those 12 is English. Once we get Korean, it will be available in 13 languages. And again, as Martha said, if you speak a language that's not on that sheet, please contact one of us afterwards, because we'd love to make this relevant in all languages. Also wanted to highlight there is within that Global Alliance, you saw over 400 volunteer contributors in the data working group. It's what David Hausler from University of California, Santa Cruz, the leaders of that group, it's what he refers to as geek power. These are the deep data scientists, computer scientists, bioinformatics, health informatics people who speak a language of their own that's in zeros and ones, and they often don't speak the same language as any of the 12 I just showed you. They have their own website, their own developer site called ga4gh.org. So if you Google us and get yourself into a place where it really doesn't look like you might have found your way onto the developer site, move back to Genomics and Health, which is where the rest of the Alliance is. They're incredibly active on a 24/7 basis. They do most of their work online, and they do it through a process. They use things like GitHub, and they use Apache Foundation approaches to how to create new data products. When I think about the work we've been doing, I'm going to drop it into 3 broad categories. And I think what we've seen increasingly is that before you can share data or before you can create knowledge, you have to discover where the data is. And our preeminent project that's focused on data discovery is the Beacon project. I'll come to it in a minute. So think about data discovery, meaning from us, it's a beacon approach. In data sharing, those three fundamental products and all the drop-down products that come, making them available to our projects, to other people, but from those kind of tools and solutions comes the capacity, the capability to share data. That data stays at that level. It's not useful until we can turn it into knowledge. And so we have three areas where we're looking at knowledge creation, knowledge exchange, by pulling that data together, learning from it, curating it, elevating it, and making it available. That's why I'm calling the knowledge exchanges. BRCA Exchange Matchmaker are up and running. Still got lots of work to do. There is a new one coming in the area of somatic cancer. The demonstration projects, therefore, are not, we don't own them. They're undertaken by many of our members, and it changes from project to project. We catalyze them. We throw our coordinators, our working groups at them as expert resources and facilitators, and we try and keep them clinically relevant. Beacon is not clinically specific. The other two very much are, and the emerging one clearly is. I'll just let you read that, but Beacon, I already said, is in the area. It's an open web service. In its earliest and easiest iteration, it was a public site to discover something very simple. Do you have this allele at this position on this chromosome? Yes, no. As we evolved it, we've made it into a network. You can ask that question once and get many answers. The evolution of it, though, will come when we can ask better questions, richer questions, deeper questions. And the idea is you'll know which data set you need to go and collaborate with. Matchmaker very much in the work of rare disease. Kim Boycott, who I think was here earlier, is she's a Canadian leader within this Matchmaker Exchange and one of the leaders on a global scale for this federation approach to rare disease matchmaking. And you'll see the BRCA challenge, and that was a challenge to the world to pool, aggregate, improve data for BRCA-related risk. But the product that came out of that challenge is the BRCA Exchange. It's not the only approach to this in the world, but we're clearly trying to challenge the community to lift up and put in the public domain as much knowledge as possible. Our somatic cancer approach really came from a recognition that there is much to be done in the world of somatic cancer, particularly about what is actionable and what is not actionable. When I look at them a little bit more specifically, there are now 20-some institutions who've lit 60 beacons. Those beacons, which is really it's an API that sits on top of a data set and illuminates the data. They can reveal 250 data sets. We've had 60,000 queries into that, and we've probably got 100,000 unique data sets within it. There is some duplication. Talked a little bit about the somatic cancer. It's evolved very much in this within the last year, and trying to make sure that we're doing something relevant. We pulled together over 100 individuals who came to the AACR this year and attended our planning meeting. And you can see that there's many, many initiatives going on around the world, these national initiatives, the Moonshot Initiative in the US, Genomics England work in the UK, and with a strong cancer component. So the goal here is not to try and start something new and separate and distinct, but to leverage the existing work that's going on and see if we can take what are national initiatives and make them into international or global initiatives. And as all of you would know, many of the challenges in this field are around funding, stability, sustainability. I will just pause and say that you'll see in there on the third bullet at the very bottom, if you can read it, it says a shared public ledger. That technology often known through the blockchain approach, and most usually in the product Bitcoin, is a very, very different approach to how to share and present data and keep it in a ledger. And so one of the opportunities here is with a new project to try a new approach to technology, knowing that we need to bring together some people who are well outside the genomic field and bring in technologies from elsewhere, apply them, see if we can make it work, and move forward. If we can't, we've got some good, old, true tested methods, federated data and APIs, but this could be a game changer if we can make it work. So I'm going to look at some of the challenges and opportunities we've got from these last 3 years of operating in this space, and then try and move closer into how does that relate to global research and local medicine. What we've seen everywhere is that the boundary between research and clinical care is blurring, and it's not just about the role of clinical trials in the middle, but we see research becoming clinical care, directly related to clinical care and vice versa, and we see that perhaps most clearly in the area of things like rare disease. We also see that linking research and health data is critical, but once you start to put health data into what's traditionally been genomic research data, it massively complicates the issues of data sharing and privacy, and particularly across jurisdictional national boundaries, or even provincial. I put a line in here. There was a question, I think yesterday, maybe this morning, about patient attitudes to data sharing. And I did some quick looking at the data that we've got, and we haven't worked it through, we haven't synthesized it into a comprehensive look. But one of the things to share with you is typically what we see is if the general public's approach to sharing their health data for research purposes, typical general public across a broad spectrum, maybe about the 50 to 60% willing to share, depending how the question is phrased. But if we look at systems like Geisinger with its MyCode, we're seeing 95% to share within the Geisinger system. Or if you look at things like the Sage Bionetworks and their Empower study on Parkinson's, or 23andMe and their studies, we see 85, 87, 95% willingness to share data. So there's a higher willingness from patients. And anecdotally, what I see is the rarer the disease, or the more consequential, the more deadly the disease, the more urgent, then the patient imperative to share becomes overwhelming to the point where they're incredibly frustrated at others like us not sharing that data. Their passion, their need to get that answer trumps their other concerns. So, from Chuck Friedman from Michigan showed this at a Institute of Medicine workshop about 18 months ago. Talked about a learning health system. Victor mentioned this morning. And that really, if we were in a learning health system, this is the way. You'd start at the bottom, you'd go around on the left-hand side doing research, and it would translate into clinical practice. And his point was, but in reality, we're not doing that. We do the left-hand side, we elevate it, we present it in conferences, we publish it in journals, and we hope somehow that rains down, that information, that knowledge rains down on the clinical setting. When he showed this, it resonated with me. I come from being the CEO of the Canadian Cancer Society. We'd advocated hard for FOBT-based colorectal cancer screening. We'd achieved it. Ontario was one of the first jurisdictions in the world to do population-based screening. But the evidence that you could get a 16% reduction in mortality had been there for 15 years before we were able to move that into public practice. So a huge time lag between knowing something and actually changing the way healthcare was delivered. So I tried then to apply that and said, well, if that's the situation within a single health system, be it a hospital, be it Kaiser, be it Ontario or Quebec, if that's the cycle of learning that we should have but we don't have, what does that do when we look at it on a global scale? So if we have the same approach and we end at this point in the cycle, that information it's come from research around the world. It's now available for almost everyone to read or study. So that cycle still remains, but I don't think it's as easy as that. And part of the question is, if you look on the left-hand side of that, genomic research has got a proud tradition, tremendous legacy of being able to do international collaborations. I've shown 4 of the biggest projects here. There's half a dozen others that you'll be aware of. There are right now something like 70 genomic data sharing research initiatives in the world going on, from small to large. Some are national, some are international. So a huge tradition on genomic research of sharing data, principles for 10, 15, 20 years about the need to do that, to share it quickly, share it broadly. Still goes into those places. And when we look at healthcare, it's not one jurisdiction, it's not one globe. It's thousands of different healthcare systems. And if we look at Canada alone, it's 14 distinct, 10 provinces, 3 territories, 1 federal employee system. So 14 distinct approaches here. Your chances of getting a new cancer drug almost entirely depend on which province you live in. It's 21 out of 24 if you're in BC. It's 4 out of 24 if you're in Atlantic Canada. Not the science, not the data, not the efficacy, where you live. I didn't win that battle, as you can tell. So when we look at the jurisdictional challenges that go with it, they're about health expenditures, about legal systems. That should say languages, not programming languages. I hope the programming languages are the same. It's infrastructure, it's human resources. It's that sense of how we deliver healthcare is incredibly varied, it's disparate. And so their ability to take genomic knowledge and apply it into healthcare is much impacted by that system. I'll just show you one slide that on the expenditure side, there are 25 countries in the world that spend over $3,000 per capita per year on healthcare. There are 23 that spend less than $100 per year per capita on healthcare, and a global average of just over $1,000. You can clearly see that if you're in the US and it's $10,000 per capita, it's not going to be the same in a country that's less than 100. If I look at another example in terms of genetic laboratories, genetic clinics, we could extend this to look at clinical geneticists, genetic counselors. There is a massive looking around the world at the availability of human resources who could take that genomic knowledge and apply it in a healthcare setting. When I leave here and run out of the door, I head to Brazil. They showed some statistics last time I was there that showed they had, let's say, an average of 100 genetic counselors, but half of them were in one state. And there were states with significant populations and no genetic counselors. Exactly the same picture in Malaysia. So that distribution of resources in healthcare, who can make sense of it, varies so much. And you know this. So I looked at it again as to what can we, the Global Alliance, do. We can't fix global healthcare disparity, inequity, human resource capacity. We can work with others to point out that has to be done to finish the learning. But what can we do? And what we can do is things about interoperable data sharing and learn from what we've done on the big research side. So with these APIs, with standards, with frameworks, but not design them for the big research environment. First time I've done this, and it worked. Design them on a global scale so they can work anywhere and so that they can work in both the research setting and the healthcare setting. And so look in the design of the tools we make, not something that requires 30 bioinformatic engineers in order to be able to understand how to operate the software or run the program, but do it in a way that is much more accessible to many more people. If your APIs are correct, then thousands of people can knock themselves out writing great apps to sit on the data and read the data and analyze the data. If the APIs are not in place, the apps won't work. Talked about Beacon already. First of all, you've got to discover where that data is. And I just showed our two, the BRCA and the Matchmaker Exchange. But clearly, for this to work, it's not about these two exchanges, but it's about people having that attitude, that approach of data sharing is only a prerequisite to creating knowledge and then sharing that knowledge. And I'll use the example, if instead of, we still must publish it in journals. We still must present it at conferences. We've got to learn peer-to-peer. But that idea of being able to use modern computer technology to lift this information up so that it starts to look more like a GPS or a sat-nav approach to finding out where to drive, rather than opening maps and reaching to the back or stopping to ask somebody. Put the information in a way that is accessible to many. Some of the lessons learned, I already talked about APIs. Sometimes you do need standards. We've done a fair amount of work on the file formats, VCF, BAM, SAM, and the emerging CRAM. Sometimes you need format standards, but typically it's about how the data talks from one level to the other. You can address the international area very much by the use of federation and the use of metadata. You don't have to move the data. The data is too big to move, and often it's restricted. What you can do is send the question to the data, as opposed to sending to the data out of the country, out of the region. So federation of data, use of metadata. Data discovery is prerequisite. This doesn't work when you can't read what's behind the little thing. The genomic data is relatively simple compared with human data, with phenotypic data. So something that can be reduced to 4 base letters is very, very different from trying to understand what 100 different physicians meant in that code that they used to describe that disease. So most of the challenge we're having is how do you standardize, how do you synthesize, how do you lift up human data. The other thing is clearly where we're going, this is not something that humans alone can start to make sense of this data. We have to give better tools, better algorithms, better performance of computers to be able to do the interrogation. So when I boil all this down to the last few slides, my sense is that we'll talk a lot about precision medicine in the developed world. And we'll talk, and Victor said this morning, and talk about better population health in the developing world. The power of this knowledge that we're generating in genomics and in omics has got mass application in the developing world, but it will not be the same as it's applied in North America or in Europe. My sense, therefore, is do the global research, bring up the knowledge, make the knowledge available, know that it will be applied differently around the world. For us, for the Global Alliance in 2016 and beyond, individuals from the beginning have been there's nothing that we've done that hasn't been created by individuals. So people are absolutely essential to creating the tools, the solutions, the forward-looking approaches. But organizations are key to ensuring that their product is disseminated and it's adopted. So we need both. We within the Alliance need both. We as a community, as an ecosystem, need both. Passionate individuals to break through, organizations to endorse and support. For me personally, we say it's a global alliance. It is. It's big, it's broad. But if we look at one layer underneath the surface, it's very much still an Anglo alliance. It's US, it's UK, it's Australia, it's Canada. It's half Anglo. But it's a developed world Anglo. It's the people who did the big genome research. And that's a lot to do with capacity. So the reason I'm heading off a plane to Brazil for the 3rd time in 18 months is I need to go there. I need to go and listen. I need to go and learn. I need to participate. I've done the same in Japan. I've done the same around the world. But people need to know that this is not about the developed world or North America flying in, taking their data, taking their research subjects, pooling the data, publishing a paper. This is about a genuine approach to increase their capacity to be part of this global world. I would ask you all, if you're interested, then join us. And the ways to get engaged with the Global Alliance, go to our website, read the paper that we have, the perspective paper that was in Science last week. We've just launched a survey on participant values on data sharing. That's your DNA, your say. I would encourage you to go and do that. And I'd also say become an individual member. It's the best way to connect with us directly. And if you have that capacity, then please ask your organization to become. And with that, say thank you.
Thank you very much, Mr. Goodhand, for this interesting talk. So if anyone has a question, please come to the microphone, tell us your name and your affiliation. Maybe I can start with my own question. What about the implication of industry? Are they using your framework? Are they sharing their data? I know there's confidentiality and competitive, but at a point they may be able to share their data too.
Yeah. So remember that there was a point when I said not everyone in the Alliance has data to share. So what we're seeing very much is 40% of our members are industry. It ranges from the biggest information technology companies to the startup genome analysis companies. The pharmaceutical industry is there, and significantly. And I would say that the early engagement, because we've been about developing the tools and solutions, has been from the Google, Amazon, Microsoft of the world, looking at how you create tools that can be used in the cloud, and very much about that data working group. What we haven't seen yet is heavy engagement of industry with data and finding mechanisms in which we can share it. For all those reasons you just said, we're starting to see that in the Matchmaker Exchange and in the BRCA Exchange. Certainly in the BRCA Exchange, we need the clinical diagnostic labs, and they're increasingly putting whether they put their information into ClinVar in the US or working with us directly. There's tremendous learning if we can bring that information from the private labs. I think in the pharmaceutical industry, as they go down their journey of open clinical trials and proactively looking at what data they can lift up into the public domain, the more that starts to have genomic information associated with it, the more we intend, and I presume that's why they joined the Alliance, that they'll be sharing that data using our standards and approaches. Certainly people were very interested from both sides, private and public, in the area of consent. And how do we move from traditional consents in different ways into more of a patient-centric consent? And a lot of discussion about dynamic consent and the ability of the individual to control how much they share of their information. A little bit scary for people, the idea that the patient can regulate, but certainly coming from the patients groups themselves, and particularly the rare disease community, a very strong sense that they do not want to just be research subjects or patients. They are active participants in their own care, and they intend to exercise that voice. So early days yet for industry sharing data. What we're seeing, though, is a willingness to recognize there is a pre-competitive space. And if you can create that pre-competitive space, populate it with good data, then people can compete downstream, whether that's academic competition to do great research or commercial, but create that public space, that pre-competitive data.
Sir?
Just a question. The initiative is very much about openness and open sharing. I was wondering, when you're talking about metadata, do you advocate or even request the use of public ontologies for this metadata? Or do you, it's house-made? What kind of metadata are you using in order to facilitate the open sharing of data?
Yeah, so definitely need for ontologies, and I should have said one of the key groups that we've worked with on that phenotype side is a human phenotype ontology for the actual phenotyping, but the same approach on metadata and how to lift the data up. So we have a group that's working on it. Often the challenge when these groups form is then exploring everybody else who's in the same space, who's working at the same time. There are organizations like Research Data Alliance and others who are looking at levels of metadata. But I think our group that is now in the process of surveying across many other different spheres to find out what it is. There are people in the room who've looked at things like consent codes and other ways of lifting up data, putting it in lexicons, putting it in codes so that we can then popularize it. Because if there are too many of those, or if we don't get the buy-in to those metadata summaries, then the whole thing falls apart.
But so it's about open data, it's about publicly available ontologies that are not that are available to everybody, I suppose, right? That's what you're talking about.
So wherever possible, make that data as open as it is, but recognize within it that because of confidentiality, because of privacy, I should mention one other thing that just addresses that point, that many of the things we've done are focused on open, but I think Bartha shared with you at the opposite end of open is controlled access using traditional data access controls. And what we're exploring is this piece in the middle called registered access. And that registered access will look at that AAA of identifying something that will be give you a sense of who it is that's asking to look at the data, where they work, what they will attest, but it will not be the traditional data access. And I think what we're going to see as we do tiered access is making sure that people use that middle layer appropriately, because the ends are pretty clear. Understanding what we do in that limited control area in the middle. And I think people in the beginning will start, if they're very concerned about privacy and security, will go into controlled access. The issue will be who's comfortable to work in that middle space. And some organizations, as you know, are completely in that public domain. We push to the left, but we recognize that in order to get the data available, some people need the access controls.
Thank you very much. Ed Abraham's Personalized Medicine Coalition. I have a three-part question, very simple though. Where does Global Alliance get its funding? How much is the cost of membership? And in the end of the day, how will you know you've been successful?
Okay. So the first two are easy. The funding for Global Alliance today comes from the 3 host institutions, and then with support for different things from NIH through their BD2K program, and that's helped us on things like the BRCA exchange. NIH has also supported our plenary meetings. So NIH BD2K, Wellcome Trust itself standing primarily behind the Wellcome Trust Sanger Institute to provide some additional resources there. Wellcome Trust did host the first plenary meeting in addition to that. And then in Canada, Genome Canada, CIHR, several of the regional genome centers came together in a program called CanShare, did a competition for a network that would drive projects consistent with the Global Alliance, and a team led by Beth Knoppers from McGill won that competition. So CanShare in Canada, it's a little bit over $3 million Canadian over 2.5 years. And then the only other money at the moment comes from individual organizational members who support through sponsorship our plenary meetings. I think last time we had as many not-for-profit sponsors as we did for-profit sponsors. So it absolutely isn't the traditional approach that industry is outside sending money for the research that's being done in the meeting. We're in it together. That will be a relatively minor amount of money. There is no individual or organizational fee at the moment. And that was deliberate. If we could get the large organizations to fund the creation, we wouldn't make cost a barrier to entry, particularly for developing world. And then how will we know we've been successful? So that, from the beginning, that was part of the challenge was, what is the baseline? What is the amount of data sharing taking place? And how, as the amount of data is available to share is rising so quickly, and attitudes are changing, how can we differentiate our contribution from all others? So we're looking right now at some of these interim measures, these output measures of how many people have translated the framework, how many people have used it, how often is it being referred to, and you could apply that to our consent codes, to everything else we're doing, how often is it referenced in studies. But for me, a better measure is when I look at the national initiatives, whether they're in Australia, US, England, as those are coming forward, are our tools, solutions, APIs embedded? I was in Qatar a few weeks ago, and they thanked me for the security infrastructure document because it had saved them weeks, if not months, of ramping up with their data, information, and security policies. But more importantly, it gave them an external reference. So as opposed to having to do it locally and say, where did you get that data? It helped that it was highly consistent with what Genomics England were also doing. So for me, there isn't an easy press a button and see increased data sharing. We're going to have to use many different things. The ultimate measure, I think, of success is that the alliance could go away because we've made responsible data sharing so easy, so ubiquitous. We wouldn't need an alliance to keep developing the system. But we still have the W3C that's keeping the World Wide Web open. So presumably there'll be a role for us for a longer time. But I think this cultural shift, I hope that phase is over the next few years.
Thank you.
Hi, Kevin Little. Great talk. I'm curious, the idea of using this model as a way of getting actionable change within health systems. This is a fantastic concept. Have you been approached, or do you have dialogue with the other spin-out omics groups, the metabolomics, the microbiomics groups, to use this model and, as you say, save them months, if not years, in their efforts to share?
So it's really interesting. I get as many people interested in the organizational structure and the approach, and why we're not a legally incorporated entity. We've got host sites in 3 countries and all. How did you do this and why did you do it? And partly it was speed, and partly it was to not be affiliated or associated with one. So I've actually got presentations coming up in the next little while that are nothing to do with the science or the clinical application, all to do with organizing. How do you run a global alliance in the modern world that moves at the pace of which a data-driven society moves? A little bit with the other omics, not too much. I've got one coming up next month, which is very much looking at health assets in the developing world and how do you find solutions that they can actually implement. And that's another approach on a global scale. And their interest is, how did you do it? How did you get to where you are? How did you attract the funders? Jeff mentioned this morning digitize on the e-health, on the electronic health records. Sorry, Victor mentioned this morning the e-health records. He also mentioned the global G2MC, Global Genomic Medicine collaboration. That's very much on that right-hand side. It's on that applied genomic medicine They came out of NHGRI, and we're just in the business right now of looking at how we can co-locate our meetings, coordinate our activities, so that we can bring things up that curve and they can pick them up and move them around. So this idea of moving around that cycle in collaboration, moving across into other omic areas, and interestingly looking at healthcare itself rather than just science meets healthcare. So it's an interesting story to be able to tell to people. I forgot to be intimidated by the giant me on the screen because I can't see the giant me on my screen. I just saw me.
Not so much. François Laviolette, I am the director of the Big Data Research Center in Quebec City, Laval University. My question is about big data, basically. So at some point, you will really have big data if your project is going on. And you know then we cannot move the data. We have to put the algorithm where the data is and then just send the solution back. So do you have
Yep.
you know what to do with that?
So I mean, that absolutely what you just said is everywhere I go, people have realized if we're talking about terabytes of data, you can't move terabytes of data over any of the pipelines.
Tera is small data.
And that's relatively small when we start to see what's coming. So the idea of whether the data has to stay where it is for jurisdictional reasons, it's got to stay in Canada, it's got to stay in the US, or for just practical data communication issues, then the question is how do you send the questions? But the other one is how do you know it's data that you want to interrogate, data that you want to work on? So we have deep down in that data working group, there is a group looking at workflows and containers using things like Docker and Dockstore to find ways that you can package your questions, package your inquiries, and it can be dropped into an existing data set. And you know it's going to give you the result that you want it to do because it was pre-qualified to work. So it's not, as you know, it's not just a matter of sending random questions the way you wrote your program. You've got to know it works when it arrives. But I always say the first thing to do is know that that is a data set that you actually want to work with. Data discovery once, make the connection, get the access, and send the question in a way that is meaningful to that data set. So it's not easy, and when you get down to those folks, they are literally almost designing something in isolation. You have to keep bringing them up and say, don't make it just work for 2 large cancer data sets. Make it work for all data sets across many diseases, because that's the utility we need.
But it's not only about question. If you want to really open your source, it's about possibility of, I would like to send my algorithm, for example, in order to make some discovery.
Yeah, so there's a point where core tools, broad-based tools that could be used by anybody, but what I'm also seeing through those things like an exchange is the community that's working on BRCA risk is very different from the community that's working on rare disease, genotype, phenotype matching. And often those algorithms, those specific tools, are relevant in that project that may not be relevant there. So I think one of the challenges is always to say, what's the broad-based platform, the API that can do from top to bottom, but also where do you start to get these very specific high-value applications that you need to be able to get in. And that's where I think these communities of people with a common interest, whether it be cancer action or cancer risk or rare disease or diabetes or cardiovascular. But I think some of that, where do I get my algorithm working that data in a way that others can also do it, is in those trusted networks.
I think you will have a new member.
Okay, and you will be welcome. And it's free.
So I think we can thank Mr. Goodhand for a very interesting talk and a lot of patience when you talk.
Okay, thank you.
So you are now invited for a special citizen conference called Le Carrefour Santé Personnalisée. This public event will feature 2 panel discussions where experts and patients will share their vision of personalized healthcare and the future of medicine. The Carrefour Santé Personnalisée is open to all and will take place just beside here at 6 o'clock tonight until 8. Food and beverage are available on site. Scientific program will resume tomorrow morning, 7:15, with a symposium presented by Merck, and there will be a breakfast served tomorrow morning. So thank you for being here with us, and have a good evening. Bye.